Hi there, I'm Periobot and I'm here to help you with decision making in crown lengthening. Ever wondered what could be done to see more of the tooth structure? Well, cutting off gingiva is not always the right thing to do. So, what is the best solution to achieve sufficient crown height? Fear not, I'm here to help you out. Let us begin with the problems most often seen. Crown lengthening is definitely indicated in cases with inadequate crown height for restorative margins, uneven gingival margins, as in the case of gingival enlargement, and altered passive eruption. A mouth mirror, periodontal probe, and a radiograph of the concerned tooth is very helpful during the diagnosis and treatment planning. Before proceeding, let me first explain the core concept of biologic width to you. The biologic width consists of the junctional epithelium and connective tissue attachment coronal to the alveolar crest, which is around 2 mm. 1 mm is added to this to facilitate an intraclavicular restorative margin, which means there should be a minimum of 3 mm between the gingival margin and alveolar crest to maintain the biologic width. Another important factor is the width of attached gingiva. It is the distance between the mucogingival junction and the external surface of the base of the sulcus. A violation of either the biologic width or the width of attached gingiva could result in increased probing depths, problems with plaque control, severe gingival inflammation, and bone resorption. Now that I've clarified this concept, let's take a look at the treatment planning required for a crown lengthening procedure. It is very important to remember that the periodontal structures should be healthy prior to performing any crown lengthening procedure. When there is adequate biologic width and width of attached gingiva, a gingivectomy is indicated. The pocket depths are marked with the help of a Crane-Kaplan pocket marker, following which an external bevel incision is given apical to the bleeding points. Interdental incisions are performed with an Auburn's interdental knife, and the tissue is then removed with a curette to expose the new clinical crowns. The gingivectomy procedure can also be performed using electrocautery or laser. When the biologic width is compromised but adequate width of attached gingiva is present, periodontal flaps with osseous contouring is suggested. In the case of an undisplaced flap, a Crane-Kaplan pocket marker is used to mark the pocket depth, following which an internal bevel incision is performed apical to the bleeding points. This is then followed by a clavicular incision. The flap is reflected and an interdental incision helps to remove the wedge of tissue. Osseous contouring is performed to allow 3 mm of sound tooth structure coronal to the alveolar crest. The flap is then approximated and sutured to expose the new clinical crowns. When there is inadequate biologic width and width of attached gingiva, an apically displaced flap is indicated. An internal bevel incision helps to remove the pocket lining. It is then followed by a clavicular incision. An interdental incision removes the wedge of tissue created. Vertical releasing incisions are given extending beyond the mucogingival junction to displace the flap, and osseous recontouring is performed. The flap is then approximated and sutured to its new position to expose the clinical crown. In patients with gingivitis, a thorough oral prophylaxis should shrink the gingival tissue to expose the teeth, but if inadequate, any of the 3 previously mentioned procedures can be performed. The same also applies to patients with periodontitis, but care must be taken to treat the periodontal pocket as well. Surgical crown lengthening may not always be the solution, especially if aesthetics get compromised. In these cases, you may need to work with a friend to correct it instead. For example, extruding fractured maxillary incisors with orthodontic therapy is the treatment of choice instead of surgical crown lengthening. So the next time you see a case of short clinical crowns, take care to evaluate your patients and show a little love to the biologic width. All done. Now you're all set to refer your patients to the Department of Periodontics.